Yeah, so good evening. Today we start in gastrointestinal tract surgery, and this is 7 question in the real exam. I read the question. So it is 64 years old lady presented with painless obstructive jaundice. She is diagnosed as having localized carcinoma in pancreatic head. Which one of the following appropriate treatment? So this patient usually cancer head of pancreas presented by painless jaundice. So painless jaundice means that non-calcular. And this is localized, so not spread, so the early tumor. So anyone, what you expected the treatment for the early cancer head tumor, cancer head of pancreas tumor? Anyone have an
We
idea?
do papers procedure
Yeah,
for
bank.
carcinoma of pancreas.
Yeah, because this is just early disease, so pancreatic duodenectomy or Weber procedure, as you see in this picture, of course, we remove part of the pancreas and put jejunum on it. We remove the end of common bile duct in duodenum and put it in the jejunum. We remove the duodenum and put the stomach in the jejunum. So they have 1, 2, 3. So it is called triple anastomosis. Of course, means the patient is operable. If the patient in non-operable, so we just put a stent in the common bile duct. Okay, you can see the second question is a 80 years old lady presented with painless jaundice. Her investigation showed dilated common bile duct. Normal common bile duct is 6 to 7, maximum 8 millimeter. Dilated common bile duct mean common bile duct more than 1 centimeter. A carcinoma of pancreatic head compresses common bile duct. Here, liver contain bilobular metastasis. Here we mention this liver have multiple metastases, right and left, because nowadays in some tumor, if the tumor is localized in one area of the liver, like right side, left side, we can remove the right side or the left side. Not like in the past, we consider if the patient have metastasis is unoperable. So here, this patient is advanced cancer with multiple secondaries in the liver. So we use what we call it conservative or palliative surgery or palliative treatment. So anyone, what you expected the treatment?
We relieve the obstruction first by the ERCP and stent insertion.
Yeah, so the only solution here, we just relieve the obstruction. Don't tell the patient die from jaundice, because if the patient is jaundice for a long time, he will be suffer from biliary cirrhosis, can be suffer from ascending cholangitis, sometimes hepatorenal failure. So it is better to relieve the jaundice. The patient will die, but not from jaundice. He die from thrombosis or any other cause from the tumor. So the palliative treatment is stent insertion, and usually stenting done by ERCP, endoscopic retrograde cholangiopancreatography. 76 years old lady presented with symptom of persistent vomiting. Her investigation show gastric outlet obstruction from gastric carcinoma or gastric cancer. Her liver contain multiple metastases. So the same idea, this patient we consider inoperable because have cancer stomach and also have liver metastasis. So the appropriate treatment in advanced cancer stomach is just palliative surgery, which is anyone?
Gastrojejunostomy, bypass the
Okay,
obstruction.
bypass obstruction. So if you see here, for example, so it is just bypass, but not like this, just to bypass the obstruction. So gastrojejunostomy to bypass the obstruction. Okay, this one, the gastrojejunostomy. Of course, now it's done by stable, so it is easy. Don't take a time. Staplers. After that, we have a gallbladder disease, which is common. Jaundice is common. 68 years old man with type 2 diabetes mellitus is admitted to the hospital unwell. On examination, they had a feature of septic shock and the right upper quadrant tender. He is not jaundice, but tender Murphy sign. Imaging show normal caliber bile duct, no stone in the gallbladder. What is the following appropriate diagnosis? So this patient has mimic acute cholecystitis, but non-calcular because no stone and no jaundice. And sometimes the infection, whatever infection in the common bile duct or cholecystitis, can be complicated, but what we call it ascending cholangitis, and can cause septic shock. But usually ascending cholangitis, you have jaundice, but this patient have sepsis without jaundice, so maybe have sepsis due to other cause. So the appropriate diagnosis for these patients, what it could be?
Acalculous cholecystitis.
Yeah, acalculous cholecystitis is common in immunocompromised patient, usually uncontrolled diabetes, patient in intensive care. So it is not rare, but common usually in the advanced case or longer campancy in the ICU or long chronic disease. So can presented by acalculous or acalcular cholecystitis. Okay. Next question. 43 years old lady with well-known gallstone was admitted with a high fever and jaundice. So they have a stone, have fever and jaundice. On examination, she is looked extremely unwell. Her abdomen is generalized soft, although some mild tender in the right upper quadrant. So they have Murphy sign or tender right upper quadrant, have fever, have jaundice. Which of the following is appropriate diagnosis? Anyone?
This patient has Charcot's triad, so ascending cholangitis.
Yeah, ascending cholangitis is Charcot triad, which is pain, fever, and jaundice. If no jaundice, it is just acute cholecystitis. If the fever, jaundice, and the pain, it is ascending or acute cholangitis. Acute cholangitis can be complicated by sepsis or septic shock. This is why we give the patient two antibiotics for anaerobic and aerobic. So we give either third generation cephalosporin and metronidazole, or we can give augmentin, which is amoxicillin and clofulinic acid. Okay. Next question. 34 years old lady is admitted with 3-day history of colicky right upper quadrant pain, which radiated to her right shoulder. It is typical for acute cholecystitis or cholecystitis. The pain radiated to right shoulder because irritation or inflammation of the gallbladder irritates the diaphragm. If irritation of the diaphragm happened, the diaphragm is supplied by C4 and 5. The same area supplied by suprascapular nerve in the shoulder, right shoulder or upper shoulder. So they have referred pain or the same pain, called it referred pain. So this patient have acute cholecystitis. On examination, there is not jaundice. So it is not acute cholangitis. Temperature is high, 38.5. She is positive Murphy sign. So this is typical diagnosis of what?
Acute cholecystitis.
Yeah, so this is
Murphy sign.
typical acute cholecystitis, positive Murphy sign, and pain radiated to the right shoulder, no jaundice, and just pain and tender. Of course, this is pain usually due to fatty meal and usually contraction of the gallbladder due to stimulation of the gallbladder by cholecystokinin pancreatoxymine. Next question. 65 years old man is admitted with jaundice. Investigation demonstrate carcinoma of cancer of head of pancreas. ERCP is attempt, but the surgeon unable to cannulate the ampulla. Nowadays, it is very rare to have failed ERCP, but sometimes we can see. So this patient, the only solution is ERCP, but RCP is failed. So what is the alternative? What if the following is most appropriate next stage in management? How to manage this patient? So we need to relieve the jaundice. This patient is a cancer head of pancreas. ERCP is failed.
Percutaneous transhepatic cholangiogram.
Yeah, BTC or percutaneous transhepatic cholangiography, although it is not common nowadays, but is the only solution. Of course, guided by ultrasound, and of course, you need to measure the prothrombin time because these patients have bleeding tendency. 48 years old lady is admitted with attack of biliary colic and the investigation show gallstone. Laparoscopic cholecystectomy is performed. Following the operation, she becomes jaundice and the bile draining into the drain placed in surgical site. What is the appropriate next stage of management? First, what is the diagnosis? If the patient have jaundice, post-operative, just post-operative. What is the diagnosis? Anyone
But,
can happen either. Yes?
by the injury.
Usually it's not injury. It is early. It is slipped, not slipped. It is slipped stone from the gallbladder to common bile duct.
Yeah.
But we have this question come in two version. If we ask this patient is early, just first week post-operative, have jaundice, so most probably it is slipped stone in the common bile duct. Of course, the rare is ligated of the common bile duct. It is very rare. If the patient presented after 1 month by obstructive jaundice, what it could be? After surgery, 1 month he developed obstructive jaundice, what it could be? Usually injury of the common bile duct causes stricture. So we have two options, jaundice after laparoscopic cholecystectomy if the first week, so it is usually slipped stone from the gallbladder or ligated by mistake the gallbladder. But slipped stone is common. If occur after 1 month, so injury occur at time of the surgery, usually due to diathermy, and this injury healed by fibrosis, and this fibrosis causes stricture. So this is the two option. This is common question come twice, either 1 week or more than 1 month. In both cases, the treatment is the same. So back to the question. What is the most appropriate next stage in management? This patient now have jaundice, most probably have a stone, and because the biles come from the cystic duct, because the pressure of the bile is cause rupture or opening of the cystic duct ligature, so this patient now have a stone in the common bile duct or injury of the common bile duct. How to manage this patient?
ERCP.
Okay, so we put ERCP. So ERCP here for two options. First, if have a stone, he removes the stone. If difficult to remove the stone, he put a stent, and after that we can manage. If the patient have injury of the common bile duct or ligation or something, so we put a stent as a stent. So we leave it for longer time, like 1 month, just to fibrosis occur around the stent, so it's avoid stricture in the future. So in whatever the case, obstructive jaundice after laparoscopic cholecystectomy, the only treatment is ERCP, either to remove the stone or put a stent. Okay, next question. 34 years old lady is admitted with jaundice and undergo ERCP. The procedure is technically difficult, and she is returned to the ward still jaundice. So ERCP failed. Unfortunately, she is now severe generalized abdominal pain. Which of the following most appropriate next stage of management? First, what is the diagnosis? What happened and what is the diagnosis now? Anyone have an idea? What happened to this patient?
Can be pancreatitis.
No, pancreatitis not
Yes.
occur soon. It take a time. Any infection take a time. Of course, one of the complications of ERCP is acute pancreatitis, but take at least 2-3 days. Is not in the first day. This patient have rigid abdomen, generalized, not localized. So most probably what happened to in the duodenum?
Perforation.
This is a case of perforation due to ERCP. It's rare now, but one of the common complications can be hemorrhage or perforation. So this patient, due to several attempts to cannulate the common bile duct, failed. So duodenum have whole perforation. Even tiny perforation of duodenum is be easy to be increased because duodenum receive bile about 1 liter, pancreatic juice, gastric juice. So it is high pressure area. So even tiny hole can be enlarged. So this patient have peritonitis. So what do you suggest for the treatment of this patient?
Laparotomy.
Yes, so this patient have perforated duodenum or injury of duodenum. So the only solution is laparotomy. Okay, of course, if you need during laparotomy to make anything, I think it's better to start by laparotomy and after that looking for the common bile duct. It is one of the complications of ERCP. After that, we have some esophageal disease. 55 years old man presented with history of progressive dysphagia. Of course, dysphagia is difficult to swallow. To solid food in the past for a week. It is important when asked about dysphagia. Usually in the cancer and structure, it is dysphagia to solid food, and in cardiac achalasia, it is dysphagia to fluid. So they have dysphagia over 4 weeks. For preceding 5 years, he had a regular attended GP with symptom of dyspepsia and reflux. So this patient have long period of reflux, not response to the treatment, or she don't take a treatment. After that, she developed tumor or carcinoma. So first, what happened? What is the first diagnosis? What this patient have to become a cancer? See, now he's a cancer. The cause, say again?
Barrett's esophagus.
Barrett, what is Barrett esophagus?
Reflux causing the metaplasia of the epithelium of the esophagus.
Lower esophagus. So the chronic reflux not response to treatment or not take a treatment for long time, like 5 years. So they cause metaplasia or Barrett esophagus. Metaplasia is changed from sterified squamous epithelia of lower esophagus to become sterified columnar with goblet cell. So in this condition, if the patient not treated in the early case of Barrett, she will develop cancer. It take a time, as we see here, 5 years. So this is important. Nowadays, we have nascent fundoplication or some surgery for reflux to avoid metaplasia and to avoid cancer esophagus to develop. So the diagnosis here is carcinoma of esophagus, and the carcinoma of esophagus is one of the bad cancer, 5-year survival, and the prognosis is not so good. 40 years old woman presented with symptom of dysphagia mainly to fluid. So it is important to know here, it is mainly to fluid. They have been presented with many months. Her investigation demonstrate lack of relaxation of lower esophageal sphincter during swallowing. Of course, investigation demonstrate lack of relaxation, usually something called manometric study. It is present in most of big hospital in Malaysia. So they have, we did something called esophageal manometry, something make a curve, you can see the pressure in different area, and they give you the picture. This is a picture of barium. Nowadays we don't do barium, we do manometric study, and this is like the parrot peak or bird peak appearance. And this diagnostic of what, anyone?
Cardiac achalasia.
Yeah, so this case of cardiac achalasia. Why? This is patient is 40, female. We don't mention she is chronic smoker, dysphagia to fluid. So the usually cardiac achalasia occur in younger, female more. It is dysphagia mainly to fluid, not to the solid. And of course, nowadays diagnosed by manometric study of esophagus. In the past, we diagnosed by barium swallow. We don't do it nowadays. Okay. 4-year-old present with sudden onset of dysphagia. He undergoes an upper GI endoscopy and a large bolus of food identified in mid-esophagus. So he's young and the food is stuck in middle esophagus. He has no significant history other than congenital thoracoesophageal fistula repair soon after birth. So this patient have congenital anomaly, which is thoracoesophageal fistula, and repaired after birth. Few years later, the patient start to eat solid food and they have bolus stuck in the middle. I think this is a picture of a structure. This is a picture of different thoracoesophageal fistula, and usually who is alive is like part A or part C because not connected to bronchus, but other part usually is the patient died from aspirated pneumonia or aspiration of the milk. So maybe B or D or E, not much seen, but what you see in your life is E and and C. And this is stricture in middle. So what is your diagnosis here? So it is benign esophageal stricture. So just stricture. Okay. So this is from the history, because usually in the repair, from anatomy, the esophagus is lack of cirrhosis. So the usually hearing can be by fibrosis and cause this problem. Okay. Next question. 45 years old man undergoes an upper GIT endoscopy, or called OGT, for benign esophageal stricture. He is dilated, suffer from iatrogenic perforation at the site. Her image show a small containing leak, a small amount of surgical emphysema. So means that this patient have iatrogenic injury due to endoscope, and usually diagnosed by surgical emphysema or air. You can find, that when you put endoscope, we inject air. So this air comes in subcutaneous. We call this surgical or subcutaneous emphysema. This is dangerous because if the patient eat and drink, he can have mediastinitis, and the mediastinitis is mortality is more than 70%. So usually we advise don't drink, don't eat for some period. So he asked, what is the most appropriate nutrition option? So this patient we don't allow to eat and drink. So what is the best way to give the patient nutrition? We have different methods of nutrition, like percutaneous endoscopic tube, gastric tube or gastrostomy, nasogastric, parenteral, intravenous fluid, and nothing by mouth and intravenous fluid alone. Of course, nothing by mouth is correct, but what else we give to him? Anyone have an idea? Actually, this patient take a long time to heal. Of course, if the patient allowed to drink and eat within 1 week or 3 days, we can give him intravenous fluid alone and nothing by mouth. But in this patient, he take a long time because healing in esophagus is not so easy. So we give him total parenteral nutrition. Of course, nothing by mouth. And he asked here about the appropriate nutrition option. So it is TPN, which is total parenteral nutrition. Total parenteral nutrition will give the patient all necessary elements like glucose, free fatty acid, amino acids, trace element, hormone. So and usually given by central line. So the answer here is TPN, total parenteral nutrition. Next question, 58 years old lady has a history of worsening dysphagia. In addition to this, she has nocturnal cough. Over this time, she lost a total 8 kilo in weight within 1 month. She has enlarged left supraclavicular lymph nodes. What is the following disease is most likely diagnosis? Of course, from this scenario, left supraclavicular lymph node, meaning Furchow lymph nodes, it is with GIT malignancy, especially with pancreatic, with the stomach, and even sometimes with testicular tumor. This patient have dysphagia, have loss of weight, sometimes reflux cause aspiration or nocturnal cough. So what's your diagnosis? Anyone?
Sounds like Barrett's esophagus causing esophageal cancer in this patient.
Yeah, so the end result is has gastric carcinoma. So this is carcinoma, whatever the cause, maybe from the beginning, maybe from Barrett esophagus cause cancer esophagus, but this picture is gastric carcinoma because of the lymph node, because of the worsening dysphagia, all this. So it is a case of gastric carcinoma. Of course, Barrett esophagus is not a cancer; it's still not a cancer. So the only cancer here is gastric carcinoma. Next question, a 52 years old man with a long-standing Barrett esophagus, diagnosed with high degree of dysplasia on recent endoscopy. Barrett esophagus have both dysphagia and metaplasia. Metaplasia because the lining epithelia from stratified squamous epithelia becomes stratified columnar with goblet cell, so we called it metaplasia. At the level of the cell, because the cell have malignant picture, so we called it dysphagia. So dysphagia is a malignant character without invasion of basement membrane. It is like early stage of carcinoma in situ. So in Barrett esophagus, you can find both metaplasia and dysplasia. The lesion is multifocal, mainly distal site. What is the following most appropriate treatment? So this patient have Barrett esophagus, about to be malignant or in a stage to be malignant or can be considered like carcinoma in situ. So what shall we do? What is the next step we need to do? So what shall we do now?
Esophagectomy, cut it off.
Esophagectomy. So the classical way, we remove the esophagus and put the stomach up. So we call it stomach pull-up. It is a famous operation and done. So it is stomach pull-up or esophagectomy. Of course, now esophagectomy is associating with jejunostomy just for feeding, just to improve the patient condition. Next question, 65. 72 years old man presented with dysphagia. His investigation is found to have adenocarcinoma of distal esophagus. So, of course, Barrett esophagus is caused adenocarcinoma. All right. His staging investigated has referred to multiple metastases in the liver. What's the following most appropriate treatment? So this patient is advanced case of cancer esophagus with liver met. So here we are looking for something palliative. It is not wise to do esophagectomy in patient and this patient is terminal. So the palliative surgery here or palliative treatment is insertion of esophageal stent, then palliative treatment or chemotherapy. Of course, nowadays we can use, instead of the esophageal stent, we can use laser beam. And this laser can penetrate the tumor, so can be easy to patient to swallow. So whatever the way we make a tunnel in the tumor, either by laser or put a stent, so it is the same idea. We need the patient to just able to swallow. Next question, 56 years old lady presented with 6 months history of dysphagia. To solid. So again, dysphagia to solid is usually with malignancy. She has a long history of retrosternal chest pain and is worse in lying flat and bending forward. This retrosternal chest pain usually due to reflux and especially appear at time of sleeping. She undergo upper endoscopy, GI endoscopy, with a smooth stricture is identified. So this patient have a stricture and have reflux. So appropriate diagnosis for this patient is just anyone can have an idea what this could be.
Stricture due to gastroesophageal reflux
GERD.
disease.
Yes, because we don't mention loss of weight, we don't mention lymph node, we don't mention anything like this. So it is just a stricture due to reflux, due to GERD or gastroesophageal reflux disease. Of course, she need to treat it. She can give her omeprazole. We can do niacin fundoplication, laparoscopic. So just a treatment of reflux. 76 years old man presented with 5-week history of progressive dysphagia. Upper GI endoscopy is diagnosed Barrett esophagus. Esophagus is filled with food debris and can't be cleared, and endoscopy encounter a resistance that can't be passed. So this patient now has complete obstruction. So just recently he have dysphagia. He have Barrett esophagus before, and now he have complete obstruction. So it means that he developed the tumor. We just need here to ask you, in the lower esophageal tumor or carcinoma due to Barrett esophagus, is squamous or adenocarcinoma? So we choose one of these. Adenocarcinoma. Of course, now is adenocarcinoma. In the past, the common carcinoma in esophagus is squamous. If carcinoma of esophagus occur in middle or upper part, 100% it is squamous cell carcinoma. But nowadays, because the most common cause is Barrett esophagus, so nowadays the common cancer esophagus or lower esophagus is adenocarcinoma. Of course, both adeno and squamous can occur in esophagus. Leiomyosarcoma also rare, but can occur in the esophagus. Last question in this topics, 42 years old woman presented with 5 months history of episodic retrosternal chest pain, together with episode of dysphagia to liquid. So again, dysphagia to liquid or fluid is usually in female, in young female, is usually with cardiac achalasia. An upper GIT endoscopy is performed, no mucosal abnormality is seen. What is the following appropriate diagnosis? So this patient have no tumor, have no reflux, but they have dysphagia to fluid. So what's your diagnosis?
Cardiac achalasia, motility disorder.
Yeah, so sometimes they call it cardiac achalasia, motility disorder. Cardiac achalasia is degenerative disease. It is one of the congenital disease which presented late. Like degeneration occurs since birth, but presented maybe at age of 40. It is look like polycystic kidney. Polycystic kidney is congenital disease presented late also. So some congenital disease presentation is very late, but achalasia, of course, it is one of the degenerative disease of the mentoric plexus of the lower esophagus and inferior to relaxation. After that, still in GIT, so have some question in anus and rectum. 90 years old female presented with severe anal pain and the bleeding, which is typically occur post-defecation. She is young, have bleeding per rectum. On examination, they have a large posterior sighted fissure in anus. They have anal fissure. What of the following is the most appropriate initial management? Because if the patient not responds to treatment for 2 weeks, it's better to do surgery. But the initial management nowadays is to give what to the patient?
Topical GTN to relax the
Yeah.
sphincter.
GTN or glycerin trinitrate is a muscle relaxant. Of course, this is the same used in coronary. So they usually, of course, we give painkiller, we give GTN is the initial treatment. Of course, painkiller can be xylocaine 5% or lignocaine 5%. GTN usually taken at night because one of the side effects is headache. 43 years old male has been troubled with symptom of post-defecation bleeding for many years. On examination, the large prolapsed hemorrhoid and the colonoscope show no other disease. It is important, especially in Europe, in UK, and in Malaysia, any patient come to you with bleeding of the rectum due to hemorrhoid, you need to exclude cancer colon because cancer colon is very common in this country. So any patient with hemorrhoid over the age of 40, you need to exclude cancer colon, either by colonoscope or sigmoidoscope at time of surgery. Okay, so this is why colonoscope is done. Which of the following is most appropriate management? So here he asked about the management of hemorrhoid. Okay, so how to manage this hemorrhoid? Simple question.
Hemorrhoidectomy.
Yeah, just think simple. So hemorrhoidectomy, nowadays manual dilatation, even in fissure, is not done because can cause incontinence in some patient. Of course, incision and the drainage of 4 abscess, injection of the phenol, it is phenol 5%, it is not indicated here. Deltazine is also not for hemorrhoids, it can also use for fissure. A 20 years old man presented with 24-hour history of anal pain. On examination, they have perianal abscess. What the following is most appropriate management? So it is straightforward question. Usually GIT question is easy. So this is abscess, so incision and the drainage. Of course, in England, when we do incision and the drain, we send it for culture and sensitivity. For C bacteria, if it is a staph, no problem. If come like GIT commensal like E. coli and other, so it is better to ask the patient to come after 1 month to do examination under general anesthesia, because most probably have lower or low perianal fistula. In England also, they take biopsy from perianal abscess if the patient have perianal abscess recurrent or more than one time. So they take biopsy. Anyone know why they take biopsy from the edge of the wound? They trimming the edge and they take biopsy. Why we take biopsy in the recurrent perianal abscess in UK? To exclude which disease? Any inflammatory disease associating with perianal fistula or abscess is what?
IBD, like Crohn's
Yes,
disease.
Crohn's. Because Crohn's is common in some countries, so in the country which is Crohn's is common, after incision and the drainage of perianal abscess, especially if recurrent, they trim the edge and send the edge for histopathology to exclude Crohn's disease. Crohn's disease, you see granuloma or non-caseated granuloma, so it is important in European country, not in other country, Middle East and the Far East, we don't do that. 70 years old female is admitted with a history of passing bubble in the urine and abdominal distension. Bubble in the urine, something we called it pneumouria. Pneumouria or nematuria means that air come in the urine. On examination, she is clinically good, large bowel obstruction with central abdominal tender. She is maximum tender in left iliac fossa, no evidence of hemodynamic stability. So before investigation, what this patient diagnosis, what she had? What this disease?
Rectovesical fistula.
Yes, but what happened in the colon? What the disease in the colon in this patient most probably? She is clinically good, just have tender, so it is diverticulitis. In cancer, you don't have tender in the left iliac fossa. If you have tender, it is diverticulitis. So this patient have diverticulitis, the colon fistulated with the renal bladder, can cause bad odor of the urine and can cause air in the urine. So to diagnose, this is just CT, is abdomen and pelvis. In diverticulitis, because it's already diagnosed, we don't do colonoscope, because colonoscope can cause this diverticular to be rupture. And also we don't do cystoscope, because cystoscope also we don't see the hole because it is very tiny fistula. So the only you can see this connection or communication is by CT. So cystoscope, colonoscope, sigmoidoscope, all these of no value. Last question, I just write some explanation because this term is not common. So 53 years old man is present with full thickness external rectal prolapse. So patient have rectal prolapse. Okay. So this rectal prolapse, what is the following procedure will most suitable surgical option? So they write rectopexy. Some names, because we have funny names like Delorme, Altimers, Tersch, abdominoperineal excision, and I just put explanation like rectopexy is repaired through the abdomen and fixation by mesh. Delorme, it is perineal technique. Delorme perineal technique is done in all the patient, is something mimic hemorrhoidectomy, just remove the excess mucosa, but done in the very, very old patients, so it's not common procedure. The third procedure is perineal rectosigmoid, so you have incision from perineal and it is not suitable. Tertiary procedure using Berolin tab is still not evidence-based medicine, is still under trial. Abdominoperineal excision of the rectum, it means that this patient will stay with terminal colostomy forever, so it is not practical. So what is practical? We do repair through the abdomen, what we call the rectopexy. This rectopexy is the fixation of the rectum by mesh in the sacrum. This is the last question, but anyone in the GIT. Anyone know what is the complication or what we consent the patient for rectopexy? This important in abdominoperineal and rectopexy in male patient. This is male patient. We consent him about erectile dysfunction because in this area we have nervi argentea or pelvic splanching nerve, and this is responsible for parasympathetic erection. So this patient maybe have erectile dysfunction. So it is important in any patient with rectopexy to consent him with erectile dysfunction. So can be happened, especially in young patients. This is the first topic, which is GIT. After that, in general surgery, we have many topics. This topic is like pediatric surgery topic, bleeding disorder in surgery, how to stop bleeding, some related to transplantation and organ donation. So we started one by one. By the way, in the exam, in the real exam, we have 7 questions in these topics in pediatric transplantation and the bleeding tendency. Bleeding tendency, usually we speak about bleeding, cause of bleeding tendency, and also how to stop bleeding during surgery. We start by pediatric topic. Okay. If anyone have a question, just stop me and open the mic and tell me. So, 3 years old child insert a cryon. Cryon is part of pencil into their external auditory meatus in the ear. Attempt to remove is not being successful. Which the following most appropriate intervention? Here, they not ask, of course, he remove it. But he asked about how far it is emergency, because it is not inhaled. Of course, if inhaled foreign body, it is emergency. We admit the patient as soon as possible. But here is something in the ear, so it is not immediate emergency. Is not done in emergency department. So the answer here is operated in the next operative list. Okay, is not urgent. After that, we have 2 years old accidentally inhaled a peanut. So inhalation of peanut is different. They arrive in the emergency department, extremely distressed, cyanotic, imaging, show it is being lodged in the left main bronchus. Actually, the common is the right lower, but this is what they mention, is mentioned in the left main bronchus, no problem. What the following is the most appropriate intervention? So in the option, so what you choose? Anyone?
Immediate emergency bronchoscopy.
All right, so this is immediate emergency bronchoscope because it is life-threatening, can affect the oxygenation, so it is important to do it. Next question is a 10 years boy is shot in the head with air gun pellet. In gun pellet, this is like use it in the some for children is not gunshot. It is something used for bird, something used for training. It is not have power of penetration, so it is not dangerous. And sometimes in some area, suppose in brain, if you try to remove foreign body, maybe cause harm and the injury of vital center more than if you leave this foreign body in the skull. So this is air gun pellet, so it is not high power of penetration, not have this explosion effect. The injury remain concealed for 10 days. Imaging UCT scan show to be lodged in the frontal lobe. Of course, the frontal lobe have no motor or sensory function, although they have something related to memory and psychiatry. What the following is most appropriate intervention? So anyone can have idea about this. What should you do?
Operate on the next emergency list.
No, actually, this can Just manage conservative, don't do anything. First, because frontal lobe have no motor, no sensory function. Second, this is fixed, and sometimes if you remove it, you can cause more damage than you are expected. So it is better to leave it. It happened also in the lung. We found in some area of the lung they have a gunshot pellet or small shooting, so you can leave it if they not affect the patient life, because usually what happened, fibrosis occur around it. So just leave it, manage conservative, nothing, just reassure the family and nothing done. After that, we speak of hernias. By the way, hernia is protrusion of some part of intestine or any organ, either external or can be internal. So we have internal hernia, like the phlegmatic hernia, paraduodenal hernia. So you have a lot of internal hernias. One day, of course, most of internal hernia are congenital. One day, old infant is born with severe respiratory compromise. On examination, he has a scaphoid abdomen, like empty, and absent apex heartbeat. Absent apex heart means that not absent heart. It means that the apex heart is not in the normal position, not in the fifth intercostal space, so it is displaced. So it is not in the same position. So what the following is the type of hernia. So this patient have the phlegmatic hernia. This diaphragmatic hernia makes the intestine or the stomach up to the chest. So they push the heart up, and this is usually posterior hernia, and we called it Bogdalic hernia. Bogdalic is the name of the man who discovered it, Bogdalic hernia. We have two hernia, anterior called it Morgagni, posterior P and B. So Bogdalic hernia. Bogdalic is a posterior and usually presented by pushing up the heart sound or heartbeat, so become in the abnormal position. So it's called Bogdalic hernia. I think this is the congenital or embryology. Of course, it has become from three part and central part. Central part is very rare to have a hernia. More anterior, you have Morgagni hernia. More posterior, you have Bogdalic hernia. But in adult and in some young, we have hiatus hernia, and the hiatus hernia is three type, like sliding, paraesophageal, and mixed. Second, 2-month-old infant is troubled by recent colicky abdominal pain and intermittent intestinal obstruction. On imaging, transverse colon herniated in the thoracic cavity through midline defect. So she is young, congenital, and something in the thoracic cavity from intestine anterior, because it is midline defect, anterior midline. So what is this type of hernia called?
Morgagni hernia.
Morgagni hernia. So again, just remember, Morgagni is anterior, usually midline, and Bogdalic is posterior, and P and B. Okay. Next is a very rare type of hernia. 78 years old, obese lady is admitted with a small bowel obstruction. On examination, she had a distended abdomen. On examination, slit-like defect in the anterior abdominal wall adjacent to semilunar line. Semilunar line is the lateral edge of rectus abdominis muscle. So this is a picture. This is the picture in female, and they have the swelling here is lateral to rectus abdominis muscle. Here, this man is muscular and they have this defect. So anyone know what is the name of this hernia? This is the same, but this is maybe more clear, although it is difficult to be in muscular patient, but it's okay. So it is usually like this. What name of this hernia? We have many names here, so what we called it?
Spigelian hernia.
Yeah, so this is what we called it, spigelial hernia. So spigelial hernia is a hernia you can find in the lateral edge of rectus abdominis muscle It is usually don't cause anything, but sometimes they can cause intestinal obstruction because usually have a big neck and a big defect. Occur in female, occur in obese, lateral to rectus abdominis muscle, and called it sphenical hernia is very rare hernia. Of course, nowadays all hernia is treated by mesh repair or hernioplasty. After that, we have disease in the right iliac fossa. Started from young age, an 8 years old boy is examined by his doctor as a part of routine clinical examination. The doctor noticed a small painless swelling in right iliac fossa, mobile, and the patient otherwise well. So it is not appendix, not painful. The patient have no complaint, but have swelling in right iliac fossa, and this swelling is mobile. So it is not appendix, not mesenteric adenitis. Mesenteric adenitis occur usually in the patient have tonsillitis and he swallow the pus and can have caused this problem. Of course, inflammatory bowel disease can, but must have presentation. Irritable bowel syndrome is not accurate diagnosis. So this is what we called it mesenteric cyst. It's very rare, but can present it, mesenteric cyst. Next straightforward case is a 8 years old boy presented with abdominal pain, 12-hour history of vomiting. Of course, vomiting indicates severe pain, fever 38.3, and 4 days history of diarrhea. His abdominal pain has been presented in the past week. Ultrasound show collection in the right iliac fossa. So this patient have a diarrhea. This diarrhea misleading the doctor. He supposes it is gastroenteritis, but when we make ultrasound, which is important, they found a collection or free fluid in the right iliac fossa, so it's something serious. So what's your diagnosis?
Appendix abscess.
Yes, it's appendicular abscess, so it is important to know. Sometimes it is important to do ultrasound or abdominal ultrasound for suspected case of acute appendicitis, especially in female, to exclude ovarian cyst or ectopic pregnancy in older people. But sometimes if atypical presentation and neglected, the appendix perforated and presented with appendicular abscess. And actually, appendicular abscess, we just by laparoscope, we put a drain and suck the pus and send it for culture and sensitivity. And after 2 months or 1 month, we operated again to remove the appendix. So it is a conservative measure by intravenous fluid, antibiotic, and drainage of the pus by put a drain. Of course, nowadays, we don't need to open the abdomen to put a drain. You can put it by laparoscope. In some center can put it percutaneous drainage, but it's better to do by laparoscope to just to irrigate the area to suck the pus. Next question, a 7-year-old boy presented with 3-day history of right iliac fossa pain and fever. On examination, temperature 39.9 degrees centigrade. His abdomen is soft and shifting tender and like iliac fossa. Okay, what is appropriate diagnosis? So this is very important because we have a rare sign, we called it shifting tender. What shifting tender mean? It means that when you examine the patient, suppose this is the patient abdomen, and you put your hand here in the right iliac fossa over McBurney line. If you ask the patient to shift to the left side, you can find this tender is become more left. So this tender is moving. It is not in appendix because appendix is somewhat fixed. So if you have tender McBurney, it's tender McBurney. If our tender is moving, we call it mesenteric adenitis. It is inflammation of the lymph node. Inflammation of mesenteric lymph node, and as we know, the mesentery is moving. So shifting tender is diagnostic of the mesenteric adenitis. Mesenteric adenitis is bacteria infection, usually due to sore throat. The baby swallow the bacteria and cause irritation of the abdomen. This is why we call it mesenteric adenitis. In some books, they call the causative organism is Yersinia. So it's very, very, very important to know. Still in pediatric case or babies, a 2 weeks old child is brought to emergency department by his parent. He was slow to establish on feed, but was discharged home 3 days follow delivery. During the past 7 hours, he has been vomiting, and vomit is largely bile stain. It is important to know the color of the vomiting, because if the vomiting is not bile stain, it means that this patient have hypertrophic pyloric stenosis and they need operation. But if the patient have bile stain, so maybe the pathology is below the duodenum. So something in the intestine. On examination, soft scaphoid abdomen. Which one of the following is most appropriate diagnosis? It is duodenal atresia, or hypertrophic pyloric stenosis, or intestinal malrotation cause obstruction, or intussusception, or congenital diaphragmatic hernia. So you have many options. So which option can cause bile stain vomiting and severe abdominal pain and scaphoid abdomen? So anyone have an idea what it could be?
Duodenal atresia.
No, duodenal atresia, because duodenal atresia usually in the middle, so is not bile stained. Because you know the common bile duct open second part of duodenum. This is intestinal malrotation. Duodenal atresia can mimic hypertrophic pyloric stenosis, because you know duodenal is 1, 2, 3, 4 part. Ampulla of water or common bile duct open in second part. So usually this is the level of duodenal atresia. So it is mimic hypertrophic pyloric stenosis. So because the patient have bile, so it is intestinal malrotation. Of course, if all the patient can be intestinal obstruction, but it is intestinal malrotation. So back again. So 4 weeks old baby is developed well, developed profuse and projectile vomiting after feed, has been losing weight, and the vomiting non-bilious. Which of the following is most appropriate diagnosis? So here is non-bilious, and the common, of course, the duodenal and the hypertrophic can, but the common cause is hypertrophic pyloric stenosis, because the common presentation is hypertrophic pyloric stenosis. Anyone know what is Budd-Chiari? By the way, it is not congenital anomaly, but what is Budd-Chiari? Budd-Chiari is something in the liver like portal vein thrombosis. It's called it Budd-Chiari, and it can cause ascites and liver cirrhosis. It's very rare disease. Of course, intussusceptions is also present in baby. All right. 1 day old child is born by emergency cesarean section for fetus distress. On examinations, he has been decreased air entry in the left side of his chest. So air entry in left side is impaired. Displaced apex heartbeat means that is not in normal position. And abdominal examination demonstrates scaphoid abdomen, otherwise unremarkable. So what is your diagnosis? So anyone, what is the patient diagnosis?
Congenital diaphragmatic hernia.
Yeah, so it is diaphragmatic hernia. He don't mention which type of hernia, so it is good. So it is congenital diaphragmatic hernia. Again, if it is posterior, can be buctalic hernia. If anterior, can be Morgagni. Of course, cystic fibrosis is other disease, and it can cause meconium and have a special character in the lung after that. Okay, next question. 2 years old baby girl is noticed to become cyanotic while feeding and crying. A diagnosis of congenital heart disease suspected, but not pulmonary valve stenosis. Of course, in pediatric, we have cyanotic heart disease, non-cyanotic heart disease. One of the common cyanotic heart disease is what's called phallotetralogy. But phallotetralogy, if you have 4, if you see here, phallotetralogy, if we mention cyanotic, non-cyanotic, and phallotetralogy. Phallotetralogy mean 4, pulmonary stenosis, VSD, malposition of the aorta, aortic connected to the right ventricle, it should normally be connected to the left ventricle, so have some anomalies in the connection of the aorta. So this is fallot tetralogy. If we don't have pulmonary stenosis or pulmonary artery stenosis, we called it transposition of great arteries. So this patient have congenital anomalies, so it's not complete fallot, so it is just transposition of great arteries. By the way, we have another rare cyanotic disease, but the patient improve in crying. So the patient when cry improve. It is not heart disease. Anyone know what is this? If the patient cries, cyanosis improve. Something in ENT, in the nose.
Coronal atresia.
Yeah, bilateral coronal atresia can cause cyanosis. This cyanosis improve in crying. It's very strange but common question. All right, next question is a 6-month-old boy is brought to clinic by his mother. She is concerning that his testes are not located in the scrotum. She noticed them when she is in bath, but not at any other time. You know, in cold weather, especially in cold weather, in cold country, one of protection of the testes is shrinking of the scrotum skin because of the very cold weather. So suppose he taking the bath by warm water, so they found the testes in position. But if he come outside in the cold weather, so the scrotum is shrinking and the testis is up. This is normal, especially in very cold weather in European country and what we call the retractile testis. Retractile means that it is come up during cold weather, become down in the warm weather. After that, we have many questions about transplantation. This question is easy because, you know, in exam, we have a lot of questions. Some very, very easy, straightforward question. Some difficult. Most of the surgery question, anatomy question, pathology question is straightforward and easy. Transplantation. 38 years old lady donated her kidney to her identical twin sibling. What's the following type of transplantation? So identical twin, give him the kidney, so it is like each other. So what we call it in the type of grafting? Anyone? Of course, it is xenograft means take from animal, allo from other part, auto from the same person, iso from identical twin, so it is isograft. Okay. 53 years old man with severe angina undergo coronary artery bypass procedure. His long saphenous vein is used as a bypass conduit. What's the following type of transplantation? So he's taken from the same patient, so it is autograft. By the way, nowadays we don't use long saphenous. Anyone know which artery used now for coronary bypass? Easy, accessible in the thorax, nearby.
Internal memory.
Yeah, internal memory. So nowadays, of course, for long time, we use long saphenous vein and in the leg and make it reverse and cut the valve. But nowadays they found it is easy to take internal memory artery, and even you leave it connected to subclavian. Just leave it connected to subclavian artery and just take just ligate the intercostal arteries and take the end and put in the heart. So it is very easy, technical easy. Already you open the thorax, no need to make a big incision in the leg of patient. 38 years old lady donated her kidney to her niece. So what is the following type of transplantation? So they have not related to each other, so we called it allograft. So we just know that xeno is from animal, allo from person to person, auto from the same person, and iso from identical twins. After that, we have question about transplantation rejection. In the question about transplantation rejection, it is easy to divide it by day. For example, if the patient, we have hyperacute, acute, and chronic. So Hyperacute occur within minutes. So during surgery, maybe during 1-2 hours, they have a hyperacute rejection. So it's usually due to incompatible blood transfusion or mismatching or long donor, long sample. This is hyperacute. And it is like incompatible blood transfusion, so it is type 2 hypersensitivity reaction. The acute stage occur within 1 month. So acute stage is 1 month, and it is due to type 3, type 4 hypersensitivity. So we consider as cell-mediated immunity or delay. So we have hyperacute, acute occur in the first month, and it is due to humoral immunity. Sorry, not it is type 4. It's type 4, yes, it's cell-mediated immunity. After that, we have chronic occur due to vasculitis. So it is late and occur, it is immune complex. So just to avoid misunderstanding, it is type 2, 4, 3. So type 2 is hyperacute, type 4 is acute, type 3 is chronic. So 2, 4, 3. And according to the timing, hyperacute occur within 1 day or few hours, acute occur within 1 month, chronic can occur after many, many, many years, for 1 month, maybe 20 years. Okay, so the vital here is the number of day or the duration. So we can start one by one. 45 years old man with end-stage renal failure undergoing cadaveric renal transplant. The transplanted organ has a cold ischemic time 26 hours, warm ischemic time 54 hours. This is the time cold is outside the body, warm inside the body. Post-operative, the patient receive immunosuppression therapy 10 days. Okay, so 10 days later, so it is not hyperacute. The patient gained weight, become oliguric, feel systematic unwell. What's the following type of renal transplant complication? So just make it easy. So we mentioned hyperacute within 1 day or few hours, acute within 1 month. So here is 10 day. So what it could be?
Rejection.
Acute. All right, acute, and it is type 4 cell-mediated or delay hypersensitivity reaction. 44 years old man with end-stage renal failure, live donor renal transplant. During immediate post-operative period, good urine output is recorded. Of course, urine output usually 1 milli or half to 1 milli per kilogram body weight per hour. However, on return to the ward, nursing staff noticed the urinary castor is no longer drained. So no urine. Although vital sign, creatinine is normal, so the kidney is still working. However, urostomy is continuous to drain urine, and the urine is okay. So this patient have anuria. So something not in ureter, not in donation, is something technical in the surgery. So what it could be, this technical problem can cause anuria, or still the kidney is function, but the urine output is not suitable or not good. So what it could be? Anyone have an idea?
Uretary occlusion.
Say again?
Uretary
Renal
occlusion.
artery?
Uretary
Renal artery
occlusion.
thrombosis. Yes, yes. So this is injury or can be thrombus in renal artery or technical of renal anastomosis of the anastomosis. So it's renal artery thrombosis. Okay. Next question. No, just a minute. 92, sorry. This is blocked urinary catheter. Because everything is okay. The drain have urine and the vital sign is okay. So it is blocked urinary catheter, not renal artery thrombosis. Okay, because if renal artery thrombosis, the urine not come from the drain. So the answer here in 92 is the blocked urinary catheter. Okay, because the next question is the same but different. We can see the difference now. So the next question is 43 old men undergo live donation right side renal transplant or removal of arterial clamp. This good urine flow and the notice the wound is closed, or return to the ward. The nurse notice that the patient suddenly become anuric and the irrigation of blood don't improve the situation. So what type of renal transplant complication? So in this situation, what is your diagnosis?
Renal artery thrombosis.
Yeah, this renal artery thrombosis, because we don't mention, if you compare to the previous one, vital is normal. Urostomy means some drain related to the area is containing drain urine. So they have urine output, so this is just to block the catheter. But in the second one, they have renal artery thrombosis, so it is technical happened. Okay, because you know that it is problem even in exams, you have the same scenarios and just a little difference, and the answer is different. This is why in the real exam, we have the same question is repeated many times, but just to change a little in the scenario. So some answers here is correct, in the other scenarios is not correct. So it's one of the trick of this exam. 49 years old female is due to undergo renal transplantation. Apart from ABO compatibility, what the following is most important in matching donor and recipient organ? So apart from AB, what type of the compatibility test you need to do? Anyone?
HLA-DR.
Okay, HLD. HLA-DR. HLA is the human leukocytic antigen. It is discovered in leukocyte, but is present in all cell, but still have the name HLA. Okay, so this is HLA-DR. After that, we have, this is the last topic. So we have bleeding disorder and only have 8 questions. So we're about to finish about bleeding disorder. So what happened usually in bleeding? If you have venous bleeding or some area like in the past, like in the liver, in sacral plexus, just put a piece of gauze and compress. So compression can stop most of the bleeding. But for how long you compress is more than bleeding time. What is the time of bleeding time? Anyone? Bleeding time, how many minute or second? Bleeding time is 5 minutes, so you need to compress more than 5 minutes. So the first is compress to stop bleeding. After that, you remove the piece of gauze. You can find some spurter, you can use diathermy. Or if big artery, not important, like blood vessels, but not important, so you can ligate it. If artery important, like injury of renal artery or something, you make a repair. In some area, like in liver, we have some special sponge. We called it hemostatic sponge or hemocell or Surgicell. It is hemostatic material containing, and it is self-absorbed and can stop bleeding. So we have different type to control bleeding. So we can start one by one. 23 years old man undergoing an open appendectomy. The surgeon extends the incision medially and suddenly encounter troublesome bleeding, not from identical vessels. Usually this bleeding is from the muscle, and the actual bleeding of the muscle is very difficult to control. Which of the following is the most appropriate immediate management? So this patient extends the wound, he cuts the muscle, you know, sometimes in extend the appendical McBurney incision, you cut the muscle. If you cut the muscle, you have a lot of bleeding. So, ligate the vessels, we don't found identical vessels. We don't found special vessels. Under run vessels, use the diathermy, application of Surgicell, digital pressure first, then secure bleeding point. So in this situation, if you don't found a special spurter or special artery or small vessels, so it's better to digital compression. After that, secure the bleeding point. You can use diathermy, you can use under running suture, whatever. Okay. Next one, 45 years old man is undergo laparotomy following an incision of the skin. So it is common to see under skin, we have skin subcutaneous. In subcutaneous fat, we have many bleeding points. Identify in the dermis and subdermal tissue. So what the following is most appropriate immediate management. Of course, most of you see abdominal incision. So after you cut the skin, you can have bleeding point underneath or subcutaneous or in the dermal layer. So what we will do for this? Anyone?
Use of diathermy.
Yeah, so if you have bleeding subcutaneous, of course, it's not important, have a lot of blood vessels, so just use diathermy. Of course, we don't use diathermy in circumcision. If you need to use diathermy in some circumcision, use bipolar, because if you use diathermy monopolar, can cause gangrene of the glans penis. So don't use it in penis, don't use in digit, don't use in fingers, don't use in food, don't use in ear. So monopolar diathermy is contraindicated of all these in the organ. 33 years old lady undergoing a laparotomy when the surgeon damaged common iliac vein, which while commence a pelvic dissection. While one of the following is the most appropriate immediate management before suturing the tear. Of course, we don't ligate the common iliac. It is a big artery and it drains the lower limb because the common iliac is the drain internal and external iliac, and external iliac is the communication of the femoral vein, so we don't ligate. So we need to suture. Suture here means that repair of the defect. But he asked, what is the most appropriate immediate management before suturing? So what is your answer?
Digital pressure. Press it first.
Digital pressure, yeah. Usually, venous bleeding is very, very active bleeding. It is very, very big amount. And the vein is very thin wall, so it is easy to be injured. So first, you put digital pressure just to be relaxed, to control, to prepare suitable suture, usually Prolene 3.0 or 4.0. And you just relax, and after that put a clamp before and after, or vascular clamp to control the bleeding point, and after that make a suture or repair. Next question, we don't speak about the technique of bleeding, we speak about the cause of bleeding, because sometimes during surgery you found the bleeding is not compatible with the surgery. You can make a simple operation and found the massive bleeding. So most probably in all the people, this patient take aspirin and you don't ask him about aspirin, or this patient or oral anticoagulant, or you don't ask him about oral anticoagulant, or sometimes the patient have some hemolytic disorder, hemophilia, bleeding disorder, blood disease. So at this time, it is important to review the patient notes before you do any even minor surgery. 33 years old female is admitted for varicose vein surgery. She is fit and well. After the procedure, persistent bleeding. She is known to have menorrhagia. So of course, if the patient have menorrhagia, so you have some bleeding tendency. So now we make investigation and show prolonged bleeding time. We mentioned bleeding time is 5 minutes. And increase active ABTT, active partial thromboplastin. They have prolonged prothrombin time, normal prothrombin time, and the platelets count. So normal prothrombin time, so she is not an anticoagulant. Normal platelets, so it is not thrombocytopenic purpura, so it is not purpura. But the patient have something affecting the clotting factor or something in the clotting factor mechanism. What it could be? Of course, the protein C, protein S, and the phospholipid can cause thrombosis, not cause bleeding. So they are excluded. DIC is occurring massive blood transfusion. So it's not the answer. vitamin K deficiency is not usually. You can give vitamin K to increase prothrombin time, but prothrombin time is okay. So what this patient have?
Von Willebrand disease.
Yeah, this is have factor VIII deficiency or subtype of factor VIII, what is called von Willebrand disease. Okay, not hemophilia, because hemophilia 3 type A, B, C, factor 8, 9, and 11. Okay, next, 70 years old, Cole Miner, presented with 3-week hematuria, bruising, is normally fit and well. He is on no medication. This is important, so we exclude that he's not an aspirin, not an oral anticoagulant. His result is hemoglobin 9, a little low, white blood cell 11 with normal, platelets 255 with normal, prothrombin time 15 second normal, active partial thromboplastin 58 increased, so ABT increase, thrombin time normal. So what is likely diagnosis? So this patient have something in the clotting mechanism. Of course, not vitamin K again, and it is not Willebrand disease, not warfarin overdose, because the patient don't take warfarin. So this is rare condition. What we called it autoimmune hemophilia. So in autoimmune hemophilia is sometimes some called it acquired hemophilia or adult hemophilia or autoimmune hemophilia-like syndrome. It is usually with clotting factors, you can found this platelets is normal, so not thrombocytopenia, but you can found active ABTT is increasing, so it is means something abnormal in clotting cascade or in clotting mechanism. Okay, so it is some sort of hemophilia. Again, hemophilia can be ABC. Question 100, 33 years old female attended the day unit for elective varicose vein. She has previously had recurrent pulmonary embolism event. So they have a history of thrombosis. The patient is 33, so it is not old, so not atherosclerotic. After the procedure, persistent bleeding, the ABTT is increased. So what is most likely diagnosis? So this patient have abnormality in the some clotting mechanism, and they can cause sometimes thrombosis, and sometimes they can cause elective previous recurrent. She has thrombosis. So if you have thrombosis in this age, have three possibility: protein S, protein C, antiphospholipid syndrome. In this patient, it is antiphospholipid syndrome. Sometimes they call it anti-cardiolepine syndrome. It is not protein C, because protein C usually is have some characters different in the protein C. I forget it, but usually the ABTT not high. So the common is antiphospholipid syndrome. Okay. I think if common exams they remove protein C, because protein C sometimes it can be correct. So the correct answer here is antiphospholipid syndrome. Is antiphospholipid syndrome sometimes is can run in families. You can find the patient, her mother, her aunt have the same condition, and usually in young age. So the answer here is antiphospholipid syndrome. Okay. I will remove protein C later from this question. Okay. Next question, a 21 years old man fall into ravine while skiing, trapped with several hours. He's finally brought to emergency department, but found hypothermic. This is second topic is hypothermia. It's very common question. A patient have hypothermia, core temperature 29 degrees centigrade. In the hospital, they plan to raise the core temperature to be 37 degrees centigrade. What is the method most effective at raising the core temperature? Of course, rewarming with electrical blank is a routine. It's done in all hospital, adjusts the air condition, temperature. Usually in hospital it's 25 degrees centigrade. This is classic, but we need to warm the body, the blood. So what is way of warming we can use? They have something like warm intravesical, urinary bladder, warm rectal, warm intravenous. So what you choose? Anyone?
E, installation of warm intravenous fluid.
Yeah, so the answer is installation of warm intravenous fluid. I found in some version of this question, they write installation of warm intraperitoneal fluid. I think to put, it is theoretically correct, but can cause infection, can cause peritonitis, maybe not logic. Is not dangerous also, but is intravenous warmed intravenous fluid is better. Of course, all can be correct, but for practical, it's better to do intravenous. Warm again is not hot. Warm means that the temperature is 37 degrees centigrade, which is a normal body temperature. Last question is a 21 years old man undergoing inguinal hernia repair, receive a dose of intravenous amoxiclav, which is augmentin. He's reported to have an penicillin allergy. Over the next few minutes, his vital sign, pulse 130 increase, blood pressure 60/40 decrease. The first line of treatment. This is tricky question, although this emergency situation, but what is the route you give adrenaline? What is the route?
Intramuscular.
Intramuscular. So the correct answer is intramuscular. Yes. Okay, correct. This is the last question. I just stop sharing. Okay. So